So the way we've set up this session is that we are going to have 4 different sections, each led by a different dietitian, and there will be 1 case per section, which is a real patient from each of these dietitians. They will then give a 10 to 15-minute lecture, and then hopefully we'll have enough time for questions at the end, and of course you can always fill out those cards that are on the table and give them to the lovely Trisha James, and she'll bring them up to us. And the hope is that by the end of your time with us, you will have learned several things, including understanding how a GI dietitian works with different GI conditions, have tips for best practices regarding nutrition advice for specific conditions, and most importantly, why it's so important to have a GI dietitian that you can be working with. All right, so let's get to our first section. So our first section is called Nutrition Interventions for Gastrointestinal-Related Eating Disorders, and this is Natalie Manitius' patient. So Natalie's patient, KM, is legal sex female, identifies as gender non-binary with the pronouns they, them. They are age 23 and have a relevant medical history of hyperlipidemia, prediabetes, Ehlers-Danlos hypermobile type 3, fibromyalgia, and a recent diagnosis of gastroparesis, as well as an active eating disorder, binging, purging. So when this patient met Natalie, their current symptoms were vomiting 3 to 4 times per week, which was actually a significant improvement when they were put on domperidone, because they were vomiting multiple times a day before that point. But they were still having nausea with every time they ate, poor appetite and early satiety, heartburn despite being on Dexilant, and their bowel movements were loose and frequent, at least 8 or at least 6 per day, and Bristol Stool Form Scale type 6 to 7. The available tests and procedures were all normal except for their gastric emptying study, which showed gastroparesis, and their relevant anthropometric and biochemical information showed that they had a BMI of 45 and low vitamin D. So when Natalie first met this patient, they were currently trying to lose weight at the recommendation of their healthcare team. And so they were weighing themselves multiple times per day. They were experiencing episodes of hypoglycemia at work because they were avoiding eating to try and manage their symptoms. And they had a pretty strong history of an eating disorder. So they were actively binging and purging for the past 1 to 2 months. But they actually had an onset of their eating disorder at age 12, which was anorexia nervosa, and it got worse within their teen years, where they ended up in residential treatment, inpatient psych admission, and partial hospitalization. So they had worked with dietitians in the past and had a lot of awareness of the types of food exchanges and programs that they might put them on. So Natalie, I would love to hear a little bit about your assessment and how you worked with this patient.
Thank you, Nancee. So this patient described nausea immediately with eating. And a lot of what they were doing to manage their GI symptoms was also feeding into the disordered eating. So they were having these symptoms of vomiting, and in order to put off the vomiting, they weren't eating all day. However, given their eating disorder history, once they did start eating towards the end of the day, they were then backloading their food, and they were starting to have severe nausea and vomiting, which makes it challenging because how do you know which one's the eating disorder versus the gastroparesis? They were also told by their healthcare providers this patient needed to lose weight, so this patient was weighing themselves every day, and that was further exacerbating the eating restriction. So overall, they were very aware of the eating disorder, but there was a lot of complicated factors related to what's the GI condition, what could be RFID, and what's active eating disorder.
Thank you so much. I would love to bring you to the podium and have you give us a presentation on how you work with these patients.
Hi, everyone. My name's Natalie. Thank you for joining me. So I chose this title purposefully not to be provocative, but rather to address something that I see very often in clinic, which is that despite our best efforts at taking care of these patients, very often it's easy to create harm when we don't know the context of someone's diet. So in order to better understand this, I think it's worth knowing just how pervasive disordered eating is. So in the general GI population, eating disorder prevalence can be in up to 24% of patients. Among disorders of the gut-brain interaction, we can see RFID prevalent in up to 20% of patients. With celiac, so you'll hear from Janelle later today, one cross-sectional study found that up to 54% of patients met criteria for ARFID, which complicates things because how much of it is to manage the disease state versus something that's maladaptive and problematic. You'll hear from Christina talking about IBD today, but prevalence estimates show that up to 24% of patients with IBD can have disordered eating. And this, again, how much of it is a consequence of the malnutrition, how much of it is an effort to really manage the disease process. And you'll hear from Shelby talking about ostomies. Data on this virtually doesn't exist, but I would say in talking to patients, some factors like fear of odor, leakage, output can all affect their eating behaviors. So eating disorders in GI are complicated. It's a chicken or egg scenario, and the reality is it can go both ways. So one might present first with GI symptoms. Potentially there's IBD, IBS, functional GI symptoms, and so one may start to restrict their diet as a means of managing symptoms. However, then as this continues, and they might be grasping at straws to really control their diet, they can then develop fear of eating, and this is where ARFID can come into play. However, this can go the opposite way. So potentially someone already has an eating disorder, like our case today, and they start restricting their diet to manage symptoms, and potentially it affects their motility. They can develop issues like gastroparesis, constipation, etc. And all of this can be affecting overall GI motility, visceral hypersensitivity, so it all plays into each other. We also know that there are psychosocial effects, so thinking about the overall context in which this person lives and operates, thinking about how they were raised. So we know that statistically speaking, children born to families where there's a lot of control surrounding eating have increased risks of disordered eating. Also things like trauma, PTSD, all of these social factors can elevate the risk of eating disorders. And lastly, medical effects. So this is where if it's prolonged or severe, we can see issues with weight loss, electrolyte abnormalities, malnutrition, etc. So clearly this is all complicated. I don't expect you to parse where things started, but just knowing how these things interplay is, I think, really crucial. So looking at the spectrum of eating disorders, this does not cover all eating disorders, but I will say these are the ones you'll most commonly come across. This is also not very discrete in the sense that patients can change over the life course. So one may present with anorexia earlier in life, might become binge eating disorder later in life, but looking at things more in detail. So with anorexia is characterized by a prolonged energy restriction. And with all of these, so with anorexia, bulimia, and binge eating disorder, the hallmark is there has to be fear of weight gain as the main driver of the behavior. In anorexia, you might also see weight loss based on the own patient's history, so BMI unto itself is not sufficient criterion to evaluate eating disorder. You have to see physical consequences associated with the weight loss, and this is all as described in the DSM-5. In bulimia, there can be recurrent episodes of binging following by purging behaviors, and that could take the form of purging through vomiting. It could be laxative abuse, diuretic abuse, or in some cases, overexercise. The behavior must occur once a week for 3 months, and again is driven by fear of weight gain. Then with binge eating, so this is where there's recurrent episodes of binge eating. There's no purging as there is in bulimia. Again, fear of weight gain, but very often patients here describe guilt, embarrassment, shame. So they can have a normal, low, or high BMI, which is again where the BMI alone is not enough to look at a patient's eating disorder risk. And lastly, if you take nothing else from this, ARFID is one very critical to the GI population. So this is different in that the motivator is avoiding a negative consequence from eating. So weight by itself is not the driver here. And so patients may have maladaptive tendencies here where in order to avoid symptoms, there are negative psychosocial functioning impairments. So potentially these patients are experiencing fear of going out, they're scared of travel, there's weight loss, or family may express concerns over their eating, but they don't meet criteria for eating disorder because it's not driven by weight concerns. So in order to better understand the role of eating disorders, I think it's worth knowing what happens to the body in eating disorders. So in reality, they affect the whole GI tract. So in the mouth and the esophagus, this is primarily in patients who purge, but we can experience things like dental decay. There can be salivary gland enlargement with prolonged purging. In the esophagus, there can be issues of dysmotility, and if there's prolonged purging, there can be greater laxity of the lower esophageal sphincter, so you can see more inflammation in the esophagus, acid reflux, etc. In the liver, we might see elevated liver function tests. This is more common in patients who are restricting, and over time, this can lead to hepatic injury. In the stomach, so there can be gastric dysrhythmia as part of an eating disorder. In our patient today, there was gastroparesis, and that had developed after a lifelong eating disorder. And then throughout the intestines, so potentially with dietary restriction or hypothyroidism-like state, one may have slow motility or constipation. If there's laxative abuse, one can develop issues related to the pelvic floor. So really, it affects the whole GI tract, and this is worth thinking about if you're evaluating a patient's risk factors. So how do you start to parse out a patient's eating disorder risk? So overall red flags, this is worth knowing because eating disorders are very subtle. So sometimes you have to play detective here. And so one thing for women of menstruating age is their period suddenly absent. That's one potential warning sign. Is this also a patient who describes frequent dizziness, lightheadedness? Are they having frequent headaches? Do they have loss of consciousness? And again, this is where you as clinicians put the picture together, seeing that this isn't due to some other condition. Is this someone who experiences chronic fatigue? No matter how much they rest, they're really tired. If it's severe, they might have racing heart. So again, is this anxiety? Is this GERD? But looking at these different factors is important. And then evaluating their vitals. So is this someone having hypoglycemia, low blood pressure? With prolonged restriction, there can be electrolyte abnormalities. So for example, low sodium, low phos, low magnesium, low potassium. And then as described, elevated liver function tests. Now, as a GI provider, so some questions we can be thinking about is getting a better sense of this person's diet. So is this someone who has a history of dietary restriction? This could be someone who said they've tried 10 different elimination diets, nothing works, or are they currently restricting diet to manage their symptoms? In assessing the quality of life, so do they describe eating alone? Are they able to dine out, travel, or be social? How do they feel about introducing new foods, and have others expressed concerns? This can be helpful if someone else is in the session with them. Weight changes, so if you look at their chart weights, are their weights all over the place? Are they downtrending, uptrending? That's worth noting. And then lastly, laxative abuse or self-induced vomiting. Is this someone who requires multiple stimulant laxatives to get things going when there isn't a documented reason for that? So if you're seeing some red flags, there are formal screening tools. For example, this screening for disordered eating. This is a tool our team is rolling out. I will say this is a pretty explicit tool. So a lot of people, when you ask these questions, will kind of know what you're getting at. So if in doubt, you can ask some of these questions. And I would always preface it with, these are some questions that I ask all my patients. It's meant for me to help support you further. Do you mind if I ask some of these questions? And I'll say it's not the GI physician's role to diagnose the eating disorder. So in looking at this today, it is worth knowing how to manage the GI eating disorder, and it is the physician's responsibility to understand when there's potential harm that can come from a diet recommendation. So some questions you could ask, you could just ask the simple question of, tell me about your diet over the past few days. That can be illuminating if you're noticing there's a short list of foods that they're eating every day. You could ask the question of, have you had issues with eating because of your GI symptoms? One question we ask is, how do you describe your relationship with food? That can be a good entry point because very often people will have negative terms like fearful, there are things that I wish were better, and that can be an easy way to segue into the conversation. You can ask, have you lost weight as a result of your GI symptoms? So potential red flags here are elimination diet history. describing foods in very binary terms. So is this someone who's talking about good foods or safe foods or potentially anxiety related to foods? Looking at how they respond to the suggestion of introducing foods, both verbally and non-verbally. So if a patient is retracting as you're talking about this, if their voice drops, if they're looking away, that can be another indicator that they're hesitant to open up. So having this conversation, first and foremost, I think it's worth validating their experience. This is how you build rapport with the patient with a topic that can be very uncomfortable to discuss, but also very vulnerable for the patient. So you could say something to the effect of, it sounds like there's been some increased anxiety around food, or validating how common it is. So it's very common for patients with GI disorders to have issues and fears related to eating. You can express your concern. So this is really to build rapport with your patient. And then once you're there, I think giving them a path forward is the next best thing you can do. So you might be something to the effect of, although it can be initially uncomfortable, restoring your weight and expanding your diet is the most likely to help you with your GI symptoms long term. This can be, if in doubt, going through the GI symptoms as a motivator can build more rapport than for those who might be guarded or not receptive to the idea of potentially an active eating disorder. You could also pose the question of whether they're willing to work with a provider like a dietitian or a therapist. So some take-home points from today. There we go. So eating disorders are very often subtle or hidden. So this is why these red flags I listed here, because you can rarely ask a patient if they have an active eating disorder and get all the information on what's going on. So as a provider, we want to be considering the patient history and overall context before we're making recommendations for any type of elimination diet. And treatment for eating disorders and GI go hand in hand, so this is where the value of having your multidisciplinary team comes in. If you're improving GI symptoms, that can increase the patient's willingness to eat because they're feeling better. However, if you improve the nutritional status, can also improve the motility and overall well-being of the patient. If there's concern for eating disorders, refer to your interdisciplinary team. So at UCLA, there's Janelle, myself, and Kate, or therapists specializing in eating disorders are also a key member. And for those in the community, there are resources for dietitians specializing in eating disorders, and I have listed those here. Thank you, and I'll pass the mic back to Nancee.
Thank you so much, Natalie. And so let's finish up the case. So Natalie, I'd love to hear from you. How is the patient doing now?
Yeah, so when I followed up with this patient, we had talked about really spreading their intake throughout the day and strategies for how to get them eating during their work day. So upon follow-up, they were doing much better with energy. They were not so depleted at work. We were also talking about not weighing themselves every day. And I think talking in terms of adding more foods, like better tolerated fiber sources, liquid protein shakes when they're struggling to get some intake, really helped to give them more options and reduce some of the stigma surrounding the foods they were eating. So overall, they were feeling much better. The nausea was really significantly decreased, and the vomiting had also decreased because there was more steady intake throughout the day.
Nice, and I'm curious because what had been mentioned in the very beginning was that the patient's physicians had wanted KM on a weight loss protocol because they were worried about the prediabetes and the cholesterol. So I'm curious, how do you work with that in this type of a patient and go about it when this has been medically instructed?
Yeah, so this is a really good example of a patient who time and time again at their appointments was told that a primary concern was their weight. And this was one of their first experiences coming to a clinician and not having weight at the center and the focus of the session. So we really focused on health behaviors. We talked about better tolerated fibers. We talked not in terms of good or bad foods, but potentially how to bring in more nutrient-dense foods. And that was really validating for them and reduced a lot of the focus on weight and really prioritized health behaviors.
Wonderful. Any final words of wisdom that you want to give the audience?
Nope.
All right. Thank you, Natalie.
Yeah.
All right, so we're going to move into section number 2, which is, we're not taking, what's wrong? If you'll write your questions down, we'll do it at the end. Thanks. All right, so section number 2 is going to be nutrition interventions for complexities in celiac disease, and this is Janelle Smith's patient. All right, so Janelle's patient, SW, is a 65-year-old female diagnosed with celiac disease in December of 2022 at an outside hospital. And this was an incidental finding. The endocrinologist had noted that the patient was not responding to their osteoporosis medications, and so ran the celiac serology, and it was positive. The patient also was having transient transaminase elevation that by the time they saw Janelle was back in range. And at the time of diagnosis, they did not have any symptoms. So because they had the positive serology, the endoscopy was performed, and you can see from the results that it was consistent with a diagnosis of celiac disease. So Janelle, I would love it if you would weigh in on the labs you saw when the patient first came to you.
Absolutely. So this is a common thing that I'll do is piece together many different labs from different institutions to really do a full assessment. The first set of labs was on a gluten-containing diet at the first hospital where she was diagnosed, which eventually led to the endoscopy and confirmed diagnosis. And this was made just based on tissue transglutaminase with a normal total IgA. The next institution she saw was about 5 months on a gluten-free diet. And it's a different reference range, clearly, because the upper limit of detection is different. And I wasn't able to see what the reference range for normal was. So at that time, unfortunately, the patient was told that her diet was not working, that she was getting cross-contamination, and that she had to make some significant lifestyle changes, which we'll talk about later. By the time I see her 9 months on a gluten-free diet, we run even more variety of serologies so that we can just continue to collect more data, because trending multiple different celiac labs can give us a lot more information.
Excellent. So the patient then came and saw Janelle for the first time in October 2023. And at this point, they now were having symptoms. So they were having frequent abdominal bloating, and it was mainly occurring when they were dining outside the home or after they had a meal. And when Janelle looked into their anxiety levels around eating, what she noted was that it was pretty low at home because a lot of protocols had been put into place in the home, such as the patient cleaning the husband's side of the kitchen, and you notice it's side of the kitchen, right? Where the patient had the husband prepare his own foods, and then she would go and clean that whole area. They didn't share a sponge. They hand washed in separate sides of the sink, had separate cutting boards, and on and on. But her anxiety when dining outside the home was quite significant at an 8 out of 10. And this is even with the patient saying that she would go to restaurants where she could, pick from a gluten-free menu, as well as discussing her concerns about cross-contamination that might happen. So Janelle, I would love to hear from you what you did with this patient. What were your assessments when you first met her?
So after evaluating her adherence to a gluten-free diet, I found that it was very unlikely that she was having gluten contamination, both just from the trending of her labs. There was not enough data to really prove that, which I'm going to talk about later. But thankfully, because I can do a thorough assessment, I can say, no, I think you're doing everything properly, and the risk of gluten intake is very low. So I'm not going to recommend you do anything different other than maybe loosen up a little bit. And let's just monitor how things continue to change, because I trust that your body will continue to heal. If for some reason that does not happen, then we have more evidence that we'll need to investigate further with the gastroenterologist. So I did agree with her to continue to avoid oats, that even those labeled gluten-free, until her serologies normalize as per guidelines. And then I also affirmed her cautiousness when dining out. However, at home, I encouraged her to liberalize some of her lifestyle behaviors that have no evidence that they would have any impact on gluten cross-contact, such as sharing a sponge, using non-disposable cleaning supplies. And she was a little nervous at the advice that I gave her, but it turned out well.
Nice. And I'm curious because the patient, when she was diagnosed, had no GI symptoms, but all of a sudden she has GI symptoms. So did you attribute that to gluten exposure, or did you feel like there was something else going on with her?
It's so hard to tell. It's so complex. I think it was equally likely from incidental gluten intake when dining out, or anxiety, or just postprandial bloating from eating a meal. Again, for her, having assessed her gluten intake as very low, I recommended that we do interventions for functional bloating, such as enteric-coated peppermint, diaphragmatic breathing, and then we referred her to our GI psychology team to address the meal-related anxiety. And so again, part of my intervention is like part of the differential diagnosis, just to confirm that the symptoms are not related to gluten intake.
Great. So the patient has now seen you. There's been follow-up blood work. It's now consistently at UCLA. We have the same range. So I'm curious what you take away from the blood tests.
This is beautiful. I'm happy with this. This is a normal expected response from what I see in clinic a lot of the time. We still have positive. She's literally at 1 year on a gluten-free diet, but everything is downtrending. And I don't know what her numbers were at the very beginning. It could have been 5,000 at diagnosis, and now we're at 130. That's a win.
So this seems kind of, I see this in clinic a lot too, where we have these patients come in and they say, my doctor told me that I'm eating gluten, and I swear I'm not, and my numbers aren't looking good. So I'm curious, do we call this non-responsive celiac disease? What do we call this? And actually, I'm going to ask you to come up to the podium and tell us more about it.
Thank you. This is a very good question. And so as in this case, a lot of times at our celiac program, we're frequently tasked with determining if a patient is responding to a gluten-free diet or if they're unintentionally still consuming gluten. So I'm going to walk you through my process within our program. This is the updated ACG guidelines on diagnosis and treatment of celiac disease. This is not my scope to, teach you, but I just want to discuss some of the really key points in time for helping to inform and reassess for gluten adherence to the gluten-free diet. So at the first point of contact with the diagnosis of celiac disease, I think it's really important that we offer support and resources rather than unfortunately saying you can look it up on the internet. That often doesn't feel like a lot of support to patients. I also really recommend that we follow up. Well, I don't recommend it. ACG recommends that we follow up 3 to 6 months after the diagnosis, again, to provide additional education, confirm that everything is trending in the way we would expect, and often to address new symptoms, because some people with celiac disease have a perfect, beautiful response on the gluten-free diet. Some people have new symptoms arise, like the patient in my case. Then is my job to do a much more thorough investigation of is the adherence to the gluten-free diet adequate, and I'm going to provide some language to offer you that you might want to use in clinic as well. In our program, I see every celiac patient at least 3 times in the first year, as well as our gastroenterologists. And I think it's really necessary for building adequate gluten-free diet adherence in our patients. Finally, we have follow-up at 1 year. We want to continue to monitor serologies and symptoms, any other abnormalities to make sure things are improving, or reassess and address. If there's an inadequate response, then we can call that non-responsive celiac disease and do further workup. What's not in this figure is recommendation to follow up at year 2 and a follow-up endoscopy around year 2 on a gluten-free diet. So some of the common experiences that I encounter with my patients in our GI clinics, I think hopefully will teach us some lessons about how we can help our celiac patients to adhere to a diet. Sometimes if we test too frequently, like every 1 to 3 months, we don't see the progress that patients want to see. We don't see resolving labs. Or we see, I had one patient who took it accidentally back-to-back 1 week apart, and it went up 5 points, and she thought, oh, I ate gluten. No, it's just a normal variation. We also have the mistake of comparing results from different labs. Apples to oranges, we cannot draw any conclusions whatsoever. Not testing often enough, not checking back in with the patient in the first year, multiple times perhaps, not explaining that serologies should downtrend, but they will not normalize immediately on a gluten-free diet. Perhaps not considering other diagnoses that mimic celiac serology and symptoms, or assuming or discussing gluten ingestion before further assessing the medical picture. So approximately, studies vary, but approximately 20% of patients with celiac disease will be termed non-responsive. And this means persistent symptoms, signs, or laboratory abnormalities typical of celiac disease despite 6 to 12 months of dietary gluten avoidance. So we found that about in a third of these cases, gluten exposure is responsible for the signs or symptoms, whether it's intentional or unintentional. And I would say it's most often unintentional and a result of lack of support or education. About 10% of the time, that person is found to have refractory celiac disease. And then more commonly, 22% of the time, there's irritable bowel syndrome diagnosed. 8% of the time lactase deficiency, 6% microscopic colitis. We also have SIBO, pancreatic insufficiency, as common co-occurring conditions. Now, in only one of these cases is a stricter gluten-free diet really indicated. So that's what we're going to talk about. If there is gluten exposure, unfortunately, there could be normal serologies. I meet patients all the time who intentionally eat gluten and have a normal celiac serology panel. However, the intestinal biopsy is typically abnormal. That's typically a much more accurate indicator of diet adherence and resolution, treatment of the celiac disease. However, a lot of people don't have gluten exposure, and they may have improving labs, but they are not 100% resolved. Same with the intestinal biopsies. It can take up to 3 years is the median time for full intestinal healing for adults on a gluten-free diet. And then finally, if we don't have gluten exposure, let's say we have normal labs and biopsies, we can be very certain it's a non-gluten cause of symptoms and look to co-occurring disorders to help this person resolve their symptoms. I just want to mention that the European Society for the Study of Celiac Disease actually recommends against this term non-responsive celiac disease because it can be misleading. It can be implying the person is not responding to a gluten-free diet, whereas there's actually 3 distinct kind of etiologies for the picture we're looking at. In this case, if intestinal healing is affirmed, if this diagnosis of celiac disease is confirmed, we can go on to look at other causes of the symptoms, like I said. If there is found to be continued intestinal damage, elevated serologies, then it's important to further work up for refractory celiac disease. And all of these patients that I've seen have no intentional gluten intake, and it's, again, pretty harmful to actually encourage them to be more vigilant on a gluten-free diet. So here's some suggestions that I have to take into clinic that instead of saying, oh, it must be the gluten, that's the most common cause of non-responsive celiac disease, be more open. You know, I'd like to do more testing to determine if it is or isn't. asking them, how hard has it been? Would they be open to discussing more with a specialist, someone who might have a lot more time, like an hour in clinic we get with our patients. Instead of saying, well, you must be getting gluten somewhere, it could even be in your soap or your pet food, defer to the specialized dietitian because it's most likely not the case. In fact, accidental gluten ingestion is bound to happen for every person with celiac disease. Thankfully, most people will heal from those accidental exposures, and we need to encourage our patients to minimize those exposures. So looking at the clinical picture to see, is their body healing as we would expect, or do we need to make more behavioral changes to ensure a positive response? So what should we advise to our celiac patients in terms of minimizing accidental gluten exposure? I have about 50 citations for this one slide, so happy to provide them if you'd like them. But essentially it boils down to this. We don't need to worry about toothpaste, dental supplies, cosmetics, medications, pet food, hygiene products, adhesives, like I just licked an envelope, kissing someone who has been eating gluten, or alcohols that is made of grain but is distilled. All of these have either good evidence that they are not a source of contamination or they have no bearing in terms of their risk. What we do know, what we do need to take care with is shared food preparation spaces, washing our hands while preparing gluten and gluten-free items, not sharing condiments. They may spread crumbs back and forth. We should be coaching our patients not to consume gluten-removed alcohol. That is not the same thing as gluten-free. We also need to be careful with things like baked goods, shared utensils, loose airborne flour, as well as grain products that are maybe naturally gluten-free, but have not been prepared in a setting to prevent gluten cross-contact.
That was fantastic, Janelle. Thank you so much for that. So as we do with every case, let's finish it up. So I'm curious, Janelle, what were the next steps for this patient, and how is the patient doing now? Oops. Sorry about that.
She's doing really great. So she was helped by getting more workup and getting the positive reassurance that she was adequately following a gluten-free diet, and continues to see results. And she actually has less bloating and anxiety now, that she is less concerned about or less fearful of gluten sneaking in everywhere. And so she's able to dine out a little bit more, knowing that she's asking the right questions. She's doing really well, thankfully.
Great. And do you have next steps for her? Like the next time you see her in clinic, what are you thinking for the next phase?
So after we get like a follow-up biopsy, if that is histologically like celiac in remission, then we'll start to integrate gluten-free oats at 1 serving per day. And kind of even before that, we'll continue to challenge any fearful behaviors that she might have around gluten cross-contact, such as traveling, dining at her family's house for holidays, etc.
Great. And any final words of wisdom for the audience?
Our words have such a huge impact on these patients who are already so either hyper-anxious, hyper-vigilant, or avoidant about adherence to the gluten-free diet. So it's really important to collect more information, do more workup before making advice that affects their entire diet.
Great. Thank you so much, Janelle. And we're going to move into section number 3. Yes. So section number 3, we're calling nutrition interventions for inflammatory bowel disease, and this is Christina Fasulo's patient. So Christina's patient, PL, is a 33-year-old female who was diagnosed with stricturing Crohn's ileitis in March of 2023 at an outside hospital. The only prior medical history known was anxiety, and their symptoms prior to diagnosis is they were experiencing bloating and lower to mid abdominal pain, and they noted that they wouldn't wake with the pain, but after eating they would have the pain, and that it didn't change if they passed a bowel movement. And at that time, their baseline bowel movement was one thin movement every 3 days. So the patient went through a lot of tests and procedures, including a colonoscopy that showed that the terminal ileum had inflammation, so did the IC valve, as well as ulcerations. They had an MRE that showed inflammatory strictures, and a CTE that confirmed short segment stricturing, wall thickening, but no bowel obstruction. So PL was started on 2 courses, so over the course of treatment, PL did 2 courses of steroid treatment, the first one an extended taper. They then were put on a biologic, which was added several months after the stricture was found. So the patient had a 6-month history of this stricture before they were actually seen at UCLA, and they were also started on PEG in order to help with the constipation that they were experiencing. So by the time Christina saw them, their CRP was starting to trend in the right direction. Their symptoms were getting better. They had less pain and better bowel movements. And the only weight history that Christina had was for that session that she saw the patient. So she had their current weight of 126 and their BMI of 23, but no prior known history for weight. So Christina, I would love to know what your impressions were of this patient when you first met them.
Okay, well, I guess the first thing I'll talk about is what I noticed in the chart review. So one, as Nancee mentioned, it's been 6 months since her diagnosis, and it was unclear what nutrition advice she'd been given. She has a stricture, so a lot of patients with strictures are on very restrictive diets. On top of that, we had therapy escalation just a few months ago after 6 months, so this could be like 6 months of restrictive eating. So when I met her, that's one of the first things we discussed. How were you educated? What were you told? And by her gastroenterologist, she was told she couldn't have any fiber. She was a little confused at that, so she met with a dietitian there, and they put her on a very restrictive 5 to 8 gram fiber diet. So she was pretty scared to eat anything that wasn't a simple protein or a white rice. She did have a little bit of applesauce and sauteed carrots, but even that had a little fear factor for her. In this process, she had lost 15 pounds, which equated to 11% of her usual body weight. So although her BMI was 23, I still screened her and then went through a whole malnutrition assessment. She was found to have severe malnutrition and in the setting of chronic inflammatory condition and her significant weight loss. Thankfully, at this point in time, we were seeing a lot of her symptoms improving, which, again, that's a good indicator. Maybe we're seeing some efficacy from the biologics, but she was still very fearful about diet.
Thank you. I'd love to invite you up to the podium to share with us how you work with these patients.
Thank you. Okay, so first, let's talk about some factors that can impact the nutrition status of these patients. So with your IBD patients, there's a lot of fear of symptoms in conjunction with a lot of patients that are trying to manage their inflammation through diet. Now, unfortunately, a lot of the resources your patients might be using are the internet, social media, or other alternative providers that don't have much background in IBD. And you're going to see a lot of patients that are on pretty restrictive exclusion diets, especially if you're seeing stricture, any narrowing, a history of bowel obstructions, just from some of the evidence they're finding. So what does that lead to? I mean, that may just be as simple as it's impacting their food-related quality of life, and they're not engaging in social interactions. But generally speaking, it's even more advanced than that. So we're seeing a lot of nutrition deficiencies. I'm sure you've all seen a lot of your patients presenting with fatigue, or maybe they're not anemic, but maybe this is just a deficiency in their iron source. And even worse, a lot of these patients come to me and they're already pretty malnourished. So what are my first 2 things I'm gonna look at? 1, I want to assess their food avoidance. And then 2, I'm gonna provide them some evidence-based therapy. So we have really high rates of malnutrition in IBD. So during a flare, up to 70% of our patients are experiencing malnutrition. Even with quiescent disease, it's up to around 40%. Now, these rates are higher in Crohn's disease, but you're still seeing a lot of your UC patients significantly impacted. Now, why does this matter? This is going to be more flares, higher need for surgery, and increased hospitalizations. Now, even when your patients are there, malnutrition is an independent risk factor for greater risk of non-elective surgery, longer admissions, post-op complications, and even increased mortality. So what I have here is something that everyone can utilize in their clinics. It's a very simple tool, and this is some malnutrition screens. Now, there's still a lot of research going on which validated tool is going to be the best for an IBD population. The IBD Chorus, which is a collective with the Crohn's and Colitis Congress, they encourage through their nutrition pathway, this malnutrition universal screening tool. And this pretty much addresses your BMI and weight, along with if you are in an acute flare or having any acute sickness. Now, another screening tool that we use quite frequently with a lot of the providers that I work closely with is this simple malnutrition screening tool. And I use this for a case study patient, even with her BMI of 23. And it addresses weight loss, which for her was 15 pounds. And although she didn't have a decreased appetite, which may be a question you ask, when you tally this up, they're at nutrition risk. So this could be a really easy way to stratify your patients to know who's going to need immediate attention. One little disclaimer here, albumin is no longer used. It lacks specificity for nutritional status, and it's highly sensitive to inflammation. So what are our goals, especially during a flare? Well, we want to maintain weight and muscle mass and encourage our patients to see if they can consume adequate calories to help their bodies heal in conjunction with minimizing symptoms. So what do we do to put this in place? First and foremost, it's going to probably look like small frequent meals, because if you tell your patient they're in an inflamed state, they have greater protein and calorie needs, and they just start increasing the size of some of their meals, they're going to get more symptomatic. So work with them and slowly have them add some snacks. We want to increase lean protein. So what does this mean? Maybe you encourage protein with each snack or meal. So say they're having, instant oats for breakfast. Maybe you can make that with a skim milk or a lactose-free milk. Maybe you add a little Greek yogurt or even a protein powder. Hydration, it's going to depend on your patient's symptoms. So if they are just having more kind of bloating, it's an obstructive-like symptoms, then just ensure they're sipping adequately throughout the day. If, on the other hand, they're at higher risk for dehydration, that's when we really want to focus on those oral rehydration solutions. The key for all of these liquids, sip throughout the day, and hopefully you'll be able to build up that way without causing any additional issues. Now, for supplements, I use them quite frequently. A lot of our oral nutrition supplements can be really helpful to enable our patients to meet their goals. And with food itself, we're doing a lot of modifications to the type, the texture, and overall amounts. It really needs to be individualized to your patient because they're each going to have very different tolerances to these foods. Now, last but not least, we're going to cut back on triggers. Like I just said, individualized. One thing I see a lot is our patients have been told they will not tolerate dairy. Now, what makes that a little bit rough is dairy is one of our best sources of calcium. Now, for instance, our case study patient, she'd been on multiple courses of steroids. What happens with that? We lose our bone mineral density. What do we need? We need calcium to make sure we keep our bones strong. So when our patients are eliminating all dairy, it can be detrimental in the long term. So a lot of times it can be helpful to encourage them to just try lactose-free varieties. Now, a lot of the other things, our added sugar, our greasy and spicy foods, and our caffeine and alcohol, I'll have them gauge. There are a lot of times things that we do need to cut back on. They probably aren't going to tolerate it quite as well as they're flaring. And last but not least is fiber, and we will get into that more shortly. Okay, so what about exclusive enteral nutrition? So exclusive enteral nutrition is when our patients or any of us can use a nutritionally complete liquid diet, which is given instead of our usual solids and fluids. So your patients will use the oral nutrition supplements, and then they can have water as needed. Now, this therapy has been extensively studied in the pediatric population, in Europe, in Asia, and it's been found to be effective for induction of remission in Crohn's. I don't think it's used quite as frequently here. I think the key to this therapy, gauge your patient. I mean, we're in Los Angeles. A lot of patients want to do nutrition therapy to help themselves, so this can be something that you discuss with them. The other option is partial enteral nutrition. And this just involves having around 30 to 50% of your calories from formula and the remainder from regular food. So this has not been researched anywhere as heavily, but we are starting to see some more promising results that it may be beneficial for induction and maintenance of remission, specifically in conjunction with certain diets and for your patients that are on anti-TNFs. And this is a really easy therapy to use, and it can be helpful just honestly in helping them gain weight and something that you can utilize also to help them get into remission. So now the fun one, can patients have fiber with strictures? So we know traditionally, our patients have been asked to limit their fiber, but really this practice has very limited supporting evidence. What is key? It's careful chewing. It's modification of the texture. It's a change in particle size. So a lot of times what I'll say is, let's think of a more no roughage, but what can we incorporate so that you can still get more of a variety of food in your diet? So a lot of times we'll walk through something like this chart, and you can see there are fruits and vegetables that are included. The key really, baked, peeled, cooked really well. One of the physicians I worked with would say, can you get it through a straw? Think of that like your intestines with your stricture. So there are ways to incorporate these foods based on how your patient's doing, slow and steady. Okay, well, thank you. Okay, so food avoidance, very common in IBD based on a lot of the reasons we just discussed. So, I mean, it's depending on which piece or what literature you're reading, it can be up to 90%, as well as these restrictive dietary behaviors. So really my goal is, even if a patient's feeling better, disease is in remission, let's see what we can do to promote a healthy and diverse diet and make sure that we're reintroducing foods that they had taken out during their exclusion. So in remission, this slide's based on the International Organization on Inflammatory Bowel Disease. AGA also came out with a publication this year. The European Society of Parenteral and Enteral Nutrition actually just released one 2 days ago, and they're all very similar in their guidance. So what are we looking for? It's all very close to a Mediterranean diet, plant-forward, anti-inflammatory, and hopefully culturally inclusive. It's going to focus on your fruits, veggies, monounsaturated fats, complex carbs, and lean proteins. Now, what are the things that we need to cut back on? That's going to be your ultra-processed foods, your saturated and trans fats, added sugars, and overconsumption of alcohol and salt. Now, the other thing that we look at, and a lot of these are in those ultra-processed foods, are certain additives. Now, a lot of this research is in rat models, but we do see alterations to the gut microbiome. So we're also suggesting that our patients limit the emulsifiers, artificial sweeteners, carrageenan, titanium dioxide, and maltodextrin. Now, the last part to this that's really important is, how do you help your patients get to that next step? Now, again, a lot of them do have food fears, so we really work in a stepwise process to help them scale their diet. So I found it to be really helpful to kind of show them what we're looking for. So our step one, it's more in the pureed or blenderized form, that really small particle size. And it'll be an incremental increase. So, maybe you'll just start with a half a cup of one of these foods. You're doing okay, then maybe we move them to kind of a more combined insoluble, soluble fiber diet where your foods are cooked or fork tender. They're still doing okay, then we can advance even further and have them try some of the insoluble fiber foods. But really just remember, it's a stepwise process and it's gonna take them time, but hopefully by incorporating more of these fiber-rich foods, we're giving them all of those immune modulating benefits and providing them again to help fight their inflammation. So last but not least, just wanted to do another shout out to our new program. It's a nutrition specialty clinic. It will be myself and Dr. Lemkekai for now. If any of your patients are either interested in nutrition, you think they're high risk and would benefit, or they need help with perioperative nutrition, please send over a referral. Thank you.
Fantastic job, Christina. That was so useful. So I would love it if we could finish up with your case. So I'm really curious, what did you end up doing with this patient?
Well, because her stricture was inflammatory in nature, luckily her biologic did its magic, and her scope was pretty clean. So we were able to actually slowly increase some of the foods we talked about, and we did this in a very stepwise process. She was also interested in the partial enteral nutrition, so she's been using that on an ongoing basis. She was able to tolerate lactose-free instead of dairy-free, so we were able to increase her calcium intake. And we just worked on really balance, having the small frequent meals with protein at each meal, and she's been doing a lot better. And then last but not least, we checked her labs. Lots of nutrient deficiencies in this patient population, especially, with our Crohn's disease. We're having problems with absorption, or we're losing other vitamins and minerals through our stool losses. So this can be a really easy thing to add on to help our patients out.
Wonderful. And any final words of wisdom for the audience?
Yes, let's really work on not telling our patients they can't have fiber. Let's focus on the texture modification and small particle size, just to allow them to have a little bit of variety and not feel as restricted in their flares or even with a stricture.
Wonderful, thank you. All right, so we're going to move into our final section. Section 4, we're calling Nutrition Interventions for Ostomy Management, and this is Shelby Yaceczko's patient. So Shelby's patient, ZD, is a 37-year-old male, and in honor of Colorectal Cancer Month, I love that she picked a case that was a colorectal cancer patient. So this patient underwent colonoscopy in June of 2022. It showed a large rectal mass and poorly differentiated colorectal adenocarcinoma. They went through chemotherapy, which was completed in December of 2022, and then they had surgery in May of 2023. They underwent low anterior resection, a diverting loop ileostomy, and anastomosis at 5 centimeters from anal verge. So the relevant anthropometrics and nutrition information, this patient was 205 pounds before they were diagnosed with cancer and went down to 195 pounds when they met with Shelby for the first time. And it appeared that the patient had lost half of that weight in the past month, so that they had lost 10 pounds in the past month associated with hospitalizations. They went from being very physically active before surgery to currently doing no physical activity. And their PO intake had decreased in the past month, but they were trying to eat 2 larger volume meals, and were saying that their appetite was somewhat improving since surgery. Their ostomy was being changed about 4 to 6 times per day, and they were noting urgency as well as dark-colored stool with some mucus present. And they weren't sure of what the output was for their ostomy, but they thought it was somewhere greater than 1 liter per day. And they mentioned they hadn't had a good night's sleep since their surgery because of the urgency. And they had been placed on 2 tablespoons of psyllium husk by one of their providers and told that they could increase to as high as 3 tablespoons, and we're also on vitamin D. So Shelby, I'm really curious what you were thinking when you met this patient, and you made note of their diet recall, so would love to know what your thoughts were about how they were trying to eat.
Yeah, well, first off, hi everyone, and I love ostomies, so I could talk about this all day, but I'll keep it short in the next 10 minutes so we can stay on time. But I get, this particular patient came to me, and one of the things a lot of the patients I work with come and say is, I don't really know why I'm meeting with you for my ostomy management because I'm told that it doesn't matter what I eat or drink. So that's very consistent with what this patient told me. So we're kind of going through the recall, and he's kind of still trying to figure out why he's in this visit with me. And we're, waking up in the morning, drinking some apple juice. He's working from home at this time because he's not quite comfortable getting ready to go back to work to be able to drive. So doing something like a fried chicken sandwich that he'd pick up down the street, steam rice, fish sticks. For dinner time, having kind of a large volume, standard big portion of beef with mashed potato and not snacking at all. And prior was having a little bit more of consistent intake. And one of the things he expressed, this patient ZD, was that, if I eat 2 main meals, then I can control kind of what's going to happen later in the day. And so that way I can work and be at my laptop and be on my meetings and not have to be running or kind of feeling uncomfortable when I'm sitting in my Zoom meetings from home. So kind of really pushing a lot of the calories toward the end of the day to accommodate for the work schedule.
Great. And, I'd love to hear more about the plan you had for this patient, as well as when they came to see you, they were given certain diet instructions beforehand and what you thought about the diet instructions they were given.
Yeah, so one of the things I like to do is kind of create awareness around patients. So we start opening up the question of, do you notice that if you eat more, X happens? So creating that kind of understanding around the volume of food and how that can make a difference as far as ostomy output goes, or the symptoms that patients can experience around their meal times. So one of the things I always like to kind of test out is, hey, if we cut your meals down by 75 or 50% and we distribute those energy or those calories out a little bit differently, what does that look like for you? And I let them kind of take that away and trial that out and see if that helps support them. So we did kind of shifting from 2 larger meals to 4 smaller portion meals that were a little bit more even. And then we started shifting calories down. So I like to let patients know, think of your body is like a car. And if you're filling up your gas in the tank really close to bedtime, where's that gas going to go? So we're trying to distribute things downward where we're having majority of our energy and calories coming in the daytime when it can be more useful, as well as that can help actually with a lot of the fatigue some of these patients can experience after surgery. We talk about things, which I'll kind of tell you a little bit more in a couple of minutes, around hyperosmolar fluids. So very similar to, our IV fluids, a lot of the fluids that we drink can be considered more hypoosmolar. As far as sugary beverages, juices, sodas, things like liquid, oral nutrition supplements that come from more of a sugar base. Considering the types of fats, if these foods are more fried or greasy. And then thinking about how much, again, volume we have at one time, not just with solid food, but also considering the liquids and the beverages we're drinking at meal times. So can we do some separation techniques? Chewing food thoroughly and slowing down at meal times. Are we woofing it down, or are we having a meaningful mealtime where we're actually able to properly kind of start digesting and absorbing some of these nutrients we're taking in? We'll talk about oral rehydration solutions in a bit. And then I actually set up a plan to kind of titrate down and ideally potentially off the psyllium fiber, which I'll show you some of the evidence or lack of evidence thereof in a minute.
Great. Well, let's do it now. I'd love to invite you to the podium.
Food and fluid matters in ostomy management, and I'll give you a caveat right from the top. It may matter, and it may not matter a ton to some patients. So that's one of the first things I really do is I figure out, is this person potentially going to respond to food and fluid, or is this something that's more secretory in nature and less osmotic? So that's, something I do like to work with, because that could be a whole nother talk of pharmacology in this patient population. But do we need to focus more on the pharmacology side of things about how we're giving some of these antidiarrheals as far as timing and if they're more PRN versus scheduled? But for the purpose of this talk, we're going to talk more about food and fluid and when it can matter for your ostomy patients. So background, if you really go to the literature, the high output definition is loosely 1,500 mLs with an ileostomy. And I think that's important to know, because I get patients that come to me and they're a new ileostomy and they're right around 1 liter, but they're still being really, kind of told consistently that their output is too high. So if you really go back to the new ileostomy literature, right around 1,200 is actually considered, that kind of upper limiter. That's kind of what we're striving for, is right around 800 to 1,200 mLs of that output. So having an expectation with your patient and having them understand how to measure and come to you so they can see that progression as we see a more mature ostomy can be very helpful. Couple things to note: terminal ileal resections, we've got a decreased peptide YY secretion, increased ostomy volume, which can promote more rapid transit. We see dehydration is a very common cause of hospital readmissions in ileostomies. If you look at the literature in ileostomies, that's what you see sprinkled all over is like AKI, CKD, dehydration, hospital readmissions. So the ileostomy literature is quite strong in this area. So we see, there was a quote recently that 1 in 4 patients will actually, with an ileostomy, have CKD by year 2, which is frightening. So I think that means that all of us, we can do better to help educate patients on proper hydration with ileostomies and prevention of some of these kidney injuries that we're seeing in this population. Then we go over colectomies, and a little bit easier as far as food and fluid management. Small intestine is really able to compensate, so we're more so just focusing on hydration and electrolyte management, less so a lot of dietary pattern changes we see supportive in this population area. I will tell you, though, the evidence is not great on nutrition with ileostomies. We see, those that do respond to food and fluid, a lot of that data and literature is coming from more kind of like the short bowel syndrome area, where we're treating these patients more like this kind of loose short bowel type of diet. But there's really not great ileostomy-specific nutrition management literature out there. We do see some really awesome readmission prevention programs in some of the ostomy clinics that practice, and kidney protection protocols in place. I'll tell you, the evidence is not great with your fiber bulking agents when we don't have a colon. So you have to think with your endoleostomies, what are we trying to do with this fiber supplement? We know it binds fluid in the bowel, which is potentially contributing to further dehydration. So if we're just throwing fiber in, we know that fiber is going to bind nutrients, it's going to bind fluid. So, what are we doing with a lot of fiber in some of these patients? We have to think back and question. Marshmallows are super yummy. There's no evidence, so that's something a lot of people are like, oh, I was told to eat a bag of marshmallows a day, and I was like, do you like that many marshmallows? Is that like you enjoying that, or what's going on? So something to think about with the marshmallow recommendation. And our bile acid sequestrants, so those only with a colon and those with greater than 50 to 100 centimeters of distal ileum removed can cause fat malabsorption. So really, looking if we're treating bile acid malabsorption is very different than kind of what we're trying to do with some of our ostomy management. So differentiating those two. This is one of the only kind of in the last couple of years literature I could find as far as some of the ileostomy nutrition data out there. But I will tell you, we know that there is supportive literature as far as the burden of high output ostomies, specifically a lot of our ileostomies. We know these patients suffer from fatigue, social isolation, quality of life, anxiety and depression, reduced physical activity, AKI, which I already hit on, kidney stones. Ask your patients if they had kidney stones. You'd be, surprised how many patients that I ask and it's not documented in their chart, and they've told me I've had X, Y, and Z kidney stones at this point since I've had my ostomy in place. So that's something I think we need to do a better job of identifying. Low urine output. So what do patients do when they have high output? They stop drinking a lot, which then impacts their urine output, right? So our target is, roughly 1,200 mLs or greater of urine output in this patient population. Those with kidney stones, it's documented that 1,500 or more is actually protective. So if your patients are all of a sudden stop eating and drinking and their ostomy output goes down, the urine output goes down, that's not a good thing. We're not really treating the problem. Our patient got smart and figured out that food and fluid matters for them. So those are things to think about, as well as dehydration, hospital readmissions, and electrolyte abnormalities. This is a nice guide from UOAA, if you have not seen it, but this is kind of the management in ostomies principles that it highlights. So I just kind of went through and showed you what is recommended from this particular society. So colostomies, again, we're really focused on regular diet pattern, hydration, electrolytes. In our ileostomies is where we can see food and fluid can matter quite more. Angiogynostomies are a whole nother dialogue. Don't have time for that one today. But with our ileostomies, can we kind of space out some of the energy and calories throughout the day a little bit differently, shifting our calories downward where it can be more meaningful and matter for these patients' energy, keeping a regular schedule and staying consistent, chewing food thoroughly, or potentially adjusting for diet textures that can be impactful for output, considering potentially lower residue types of foods the first month or so after their ostomy is put in, but that's not a forever. So I have patients who, come and they say, oh, I've been on this really kind of lower fiber, low residue, and I've had my ostomy now 8 months ago. And I'm like, oh, what's going on there? So they can have a lot of these restrictive patterns too if they're not educated on how that progression or reintroduction can go. Maintaining adequate fluid levels and preventing dehydration, preventing stoma blockage, and then the use of pharmacology in this patient population. So considerations, these are a couple things I want to make note of. Just drinking more does not typically work. So telling patients, well, you got to just keep drinking more. So a lot of patients I see that get dehydrated, and I see them kind of when they get discharged, they were told in the hospital, drink more. And they're given high sugar oral nutrition supplements and a ton of water, of which we know that those are not the ideal fluids that can help with fluid reabsorption. We do know these patients that respond with food and fluid, we need to start looking at that water, sugar, salt ratio and these oral rehydration solutions that we can provide them. So even if that means maybe 25 or 50% of their fluids are coming from oral rehydration solutions, let's start there and see if that helps with their overall hydration status. Considering the bowel anatomy, while we may have the appropriate length of bowel, some of these patients very much so kind of function in a sense like an intestinal failure and or kind of a short bowel syndrome patient after their ostomies, depending on the etiology. So we need to think about that. Even if the bowel length is there, if the integrity is not there, how well are they absorbing, digesting both food and fluids? Then we have to consider the patient's baseline dietary pattern and their hydration schedule, as well as things like their quality of life, their work schedule, social support. Patients who show up and say, I can't go back to work because I can't drive, that's a problem. So we really need to investigate from kind of a quality of life standpoint what we can do differently with this patient population. Not to mention the pill burden. When you've got multiple antidiarrheals and they're taking pill after pill after pill after pill, that can be really impacting to their day-to-day life and also what matters to them. Just putting a plug in, so that's one of the reasons we created this Nutrition for Safer Surgeries program, which is a branch of our GI nutrition program to help provide education and prepare patients in advance so there's less surprises when they're in the hospital or discharged with some of these factors around nutrition after their procedures or surgeries. So that is something that we offer for our GI surgeries as well as our cancer patients. We already did this slide, so I'm going to skip it, but in case you forget anything on here, here's a recap.
All right, thank you so much, Shelby. So let's finish up the case. So is there, any follow-up that happened with this patient that you want to share with the audience?
Yeah, so this is one of the patients I like to say we get an aha moment, meaning food and fluid mattered for them. So we were able to consistently kind of shift over the diet pattern, and this patient was like, wow, I'm eating 3 to 4 meals now and things feel really consistent for me, which is really cool. Less urgency, and this patient was sleeping through the night, which was really impactful. So I don't know if any of you, I'm sure all of you have been sleep deprived at some point, but having a month of sleep deprivation because you feel urgency happening or you're scared your ostomy is going to burst because there's output, that's devastating. So I think, we need to think about these things when we're assessing these patients. Stopped drinking juices, didn't like the oral rehydration solutions. I have a whole recipe book if anyone's excited and wants to try them at home that you can use too. But we can always modify those a little bit to figure out what types of fluids these patients will, respond a little bit better to versus some of the hypertonic fluids, which tend to be the worst in some of these patients as far as absorption goes. Adjusting the diet pattern choices. So patients this patient in particular was able to create a lot of awareness around like, oh, the fried chicken and some of these really heavy types of like buttery, very dense foods really changed my output. And when I shifted my choices, I was able to see a reduction, and I feel like I'm absorbing better and I have better energy. We reduced the psyllium supplement to 1 to 2 teaspoons daily, and the patient was feeling really good and able to go back to work soon thereafter, after feeling like he was finding the right balance for him.
Great. All right, well, thank you so much, panel. Those were amazing lectures and a lot of really great takeaways, but we wanted to put a few out to the audience. These are the main takeaways from the different lectures that you heard today. And since we're running out of time, I'm not going to go through each one of them, but I wanted to put out there that if you're going to be attending DDW this year and you're curious about how you can work closer with a dietitian as a physician, we will be giving a lecture called Incorporating a GI Expert Dietitian into Your GI Practice, and it's going to include 3 different doctor-dietitian teams in different clinical settings talking about how they set up their practice, bill, reimbursements, all that good stuff. So we hope we'll see you there. And we just wanted to say thank you. If you're interested in learning more about our program, you can visit our website. You can also make referrals there. And then we're going to move into questions. And while we do that, Kate, I'd love to have you come and join the panel. And that way you'll have the full UCLA dietitian team up on the stage. And while Kate is getting settled, I'd love to start with you, Janelle, because this is a question that I have as well. And we actually got it from one of our online people. So you had talked about fecal testing in celiac disease. I'd love for you to share with us a little bit more about your thoughts around it, how you use it, when you use it, pros and cons of using it.
It's definitely emerging evidence in that there are no clinical guidelines around its use. So keep that in mind. But so far, the literature does say that it is highly sensitive to gluten intake. Gluten peptides that are hydrolyzed as a normal process of digestion may show up in everybody's stool, so not just your patients with a gluten-related disorder. It may show up in the stool up to 4 days after ingestion and in the urine up to 2 days after ingestion, although it is recommended to take them closer to the time of suspected ingestion, such as within 1 to 2 days. In studies, gluten peptides have been detected in 30% of patients on a gluten-free diet, whether or not they're symptomatic, whether or not they have elevated serologies. So it's proving to be a more sensitive indicator of diet adherence than either serology or diet questionnaire, although I would say 30% is similar to the percent we found from the dietitian assessment as well. So I can't tell you exactly how to use this. I'm just starting to use it, but I think it is very promising because we need to have a better way of assessing diet adherence than just scaring everybody.
Yes, excellent. All right, and we got a question. How do you incorporate hypermobile syndrome, EDS, into your treatment that you're working with? So for instance, in Natalie's patient, this patient had hypermobile Ehlers-Danlos. I wonder if you'll start us off, and then anyone on the panel who wants to add into this.
Yeah, so I will say in hypermobile EDS, it's very common to have a lot of dysmotility. So patients may struggle with constipation, diarrhea, gastroparesis. They can have overlapping dysautonomia, so MCAS can also be part of this picture. In this patient, and in general with gastroparesis, I would say thinking about describing your stomach almost as something that's mechanically breaking down foods or a motor, and thinking about it's going to do better with more consistent intake and also just spreading it out throughout the day. So similar to what Shelby described with her case, that's going to put less load on a stomach that's already struggling to accommodate food. So that's one thing we might be thinking about with the overall potential like bowel laxity that can come with hypermobile EDS. We want to be thinking about motility at large. So if there's something like POTS overlaying with this, we want to think about optimal hydration that can help with overall POTS management, which then can improve their eating. So usually if there's POTS in the picture, I'll start there, get their hydration and sodium intake optimized, and then see what GI symptoms remain from there. And from there, we can be thinking about volume, texture, particle size, liquids versus solids, et cetera.
Great, and I'm curious from the panel, we're seeing a lot more dysautonomia in our clinic because of long COVID, right? So I'm curious, what you said, perfect. Any other things that you're noticing with these dysautonomia patients that you just want to bring up?
I think affirmation, validation in their lived experience is a huge part of it. That's something that's really reported to us as dietitians, is not feeling believed or getting the care that they need.
Yeah, and also a lot of isolation, right? So these patients feel very isolated, so making sure that they are heard by their providers, but also getting them in touch with support groups like the Los Angeles Dysautonomia Network and places like that can be really useful. All right, Christina, next question is for you. When you're working with fiber modification, how do you help a patient advance, and when do you even know when to advance them?
Great question. So I think there's a lot of factors that are going to go into this. I mean, if they are flaring and we don't have any history of narrowing or strictures, then this may be kind of just based on their symptoms, on what can they tolerate. So I do usually start, again, a slow and steady kind of process of encouraging more foods in the diet. It's going to be a little bit different if your patient does have narrowing. Now, what is the cause here? So if they have inflammatory stricturing, then we're going to track their inflammatory markers. I'm going to communicate with their gastroenterologist that's falling. Maybe we'll see if they're scoped again on when it might be the right time. If things are moving in the right direction, then we're going to gauge how their symptoms go as we introduce more foods. And again, it will always probably be in that stepwise process, so we're never going to go straight to a lot of raw vegetables or fruits. Now, if it is based on if they're having issues based on adhesions, or if it is a fibrotic stricture, we may be on a more modified diet for a long time based on kind of what they decide to do with their disease, if they're going to end up in surgery, or if we are going to try to just kind of keep them fed and nourished with this modified texture.
Great. And I'm curious, with the eating disorder dietitians that are on the panel here, how do you work with a patient on diet modification if you don't want to do an elimination diet? What are some options that you do?
Kate, do you want to take a question?
Sure. So for a patient who's having active disordered eating or eating disorder, we do generally stay away from a full elimination diet approach, but there may still be some GI gentle nutrition recommendations we can make. For example, more of a FODMAP gentle approach where we might recommend, a few minor swaps in their diet that can make a big impact on symptoms. For example, switching them over to a slow leaven sourdough bread, which is lower FODMAP. If they're consuming a lot of higher fructose beverages, finding them lower fructose beverages that they also enjoy. That would be, those would be some examples in more of an IBS type of patient. But there are often some simple swaps we can make in a patient's diet that can really improve their quality of life without putting them in a situation where they're going to be so fixated on every intricate detail of an elimination diet intervention.
I would add too, especially one of the key conversations I have with my IBD patients is describing to them the state of the literature surrounding diet, because very often people are coming to us hoping that diet will be a cure-all for their IBD. So explaining what literature is out there, I think, can set the tone, but also the language you use is really critical. So if you're describing something as bad or something that needs to be strictly avoided, that's going to stigmatize the food and potentially make the behaviors worse.
Amazing. All right, so one final question. Shelby, I'd love to know, we focused mainly on ileostomies. How do you work with other types of ostomies?
Yeah, I think a good rule of thumb, and you all probably know this, the higher up you go, the harder it is to manage and kind of maintain nutritional status. So always going back to figuring out what the anatomy of that patient is and how, if we think they're responding to food or fluid, or we really need to dive into pharmacology and figure out how to better manage this patient's output with other agents that if food and fluid is really not responsive, and this is probably more secretory in nature.
Great. Thank you so much, panel. So we're right on time, so we're going to end it here. I want to ask for one last round of applause for the amazing panel who did a fantastic job.